Well, welcome to the Innovations in Sharps Management webinar. Normally, this is given in hospitals to nursing staff and/or techs in the OR environment. But for today, we're going to put this on a webinar approach. If you hear papers being moved in the background, I apologize. Think of it as a quality control issue. Every time you hear a paper moved, it's obviously I'm going to change the panel that you're looking at or the slide that you're looking at. The areas that we're going to cover today are identifying risks associated with Sharps injuries. We're going to discuss the incidence of those injuries and some of the statistics, which should not bore you to death because it may be a different way of looking at the injuries that occur in your own OR that might surprise you. We're going to discuss regulations, guidelines, and updates relative to OSHA and to CMS committees. I will talk a little bit about legislation and is it enough? We'll explain reasons for poor results on staff safety in most facilities. I'll try to introduce some solutions. And to a degree, I'll quickly cover audits, although that will be for another seminar. And I will give you some choices on how to prepare for safety. We'll identify risks with sharp injuries. And let me start by showing you 4 pictures of Sharps activists. These people all have something in common, not the least of which that they're in the medical field just like you. But moving on, I will come back to them. What is the worst thing that could happen to you from a Sharps injury? You can die. And although that sounds overly dramatic, it has happened. Do you remember those 4 people that I showed you before? They are all no longer with us, having acquired HIV, hepatitis C, and or both in the hospital environment. This is very serious stuff, and it's something that you have to be aware of and not just pay lip service to. What's the least thing that can happen to you? Well, obviously, depending upon the protocol in your facility, you will on a cut and or needle stick and or suture stick be asked to go to the ER, have blood drawn, 3 months later do it again, a year later again, to make sure that you're clear of any of the potential bloodborne pathogen issues that can arise from such an injury. And that will depend on the hospital's protocol and how you're set up. This seems to be the most common. And then the other side of the coin is no sexual intimacy for 3 months. Whenever I give this talk, invariably, anybody over 50 goes, yay, team, and laughs. Anybody under 50 goes, oh, how am I going to go home and tell my husband and or wife that we're going to have to be really careful in the coming months until I cleared. It's worth pointing out at this point that when you have a needle stick or a cut or any Sharps injury, there was an article a number of years ago in one of the nursing journals that said an injury is equivalent to being in a major car crash. And for those of you that have had sticks in the past and or cuts, you know exactly what I'm talking about. It is scary stuff. Now, if you're the surgeon or you've got your hands in the field for whatever reason, whether you're sucking a blood out or fluids out, a cut could require microsurgery that might cost as much as $100,000 and up to 3 months of rehabilitation, potentially the loss of your salary, although that seems to vary from facility to facility. I know of at least 3 hospitals and major institutions that have OR supervisors who unfortunately have acquired HIV or hepatitis C in the OR So this is not trivial. Some of the things that you can pick up from a stick or cut are listed here. I'm not going to go into detail on these. You're aware of them. Your chances of getting Ebola are obviously very, very low, but we put it in there because of the Texas incident a couple of years ago. What other issues can occur? Well, you can have a loss of productivity and income if the hospital sends you home and keeps you out of the OR for some periods of time. Various degrees of distress to depression, and that goes back to that equivalency to a car crash. Post-traumatic stress disorder, also not uncommon, and self-blame, which leads to underreporting. It's interesting that in today's world, 70% of these types of injuries go unreported. And if you think about that, it's kind of insane. If you do have a cut, if you do have a needle stick or a suture needle stick on a contaminated surface, your potential problems are huge if you do not report. If you go to the hospital 3 months later, 6 months later, and say, I acquired this on such and such a date on an injury that occurred in the OR, the hospital will invariably look at you and say, you live a promiscuous lifestyle. How do we know this occurred in our facility? If you get nothing else from this talk, reporting is extremely important, and it's for your benefit. The hospital can mandate safety, but only you can actually practice it. If you look at the costs of what happens if you acquire HIV or Hep C or any of them, it can run up to $80,000 to $100,000. If it's HIV, I know one nurse who contracted from a needle stick in the ER. I have HIV and hepatitis C, and she ended up paying $120,000 a year just to stay alive, and this has been going on for over 10 years. This is not trivial. If you haven't reported it, the hospital doesn't have to pay, and they won't. You look at the incidences of hepatitis C, fairly large. I mean, 17,000 new cases a year, which is a major risk to you, to the ER staff, to the OR staff, anybody that comes in contact with these patients. There are over 3 million people in the US that have these chronic infections. And obviously, some of them will spontaneously clear, others will develop a chronic hepatitis C. And getting rid of that becomes a major issue. Over 15,000 deaths a year as of 2007, and that has actually increased. Treatment of hepatitis C is developing at a rapid rate. And when I first started giving these talks live in operating rooms, the cure was not available. Now it is, and it's known as oral directly activating antiviral agents, treatments tailored to the 6 virus genotypes, and pegylated interferon, ribavirin, for example, are used to cure it. The problem with the cure is the side effects. The fevers, chills, all of the issues that you see here are very similar to what happens when you're on chemotherapy. It is extremely unpleasant. It is extremely costly. And avoiding these issues has to be a major goal for you in your OR. If you don't report and you do acquire these diseases, you're making decisions not just for you, you're making decisions for everybody that cares for you. Again, reporting is just absolutely critical in today's world. If you don't, it's your own fault. If we look at some of the issues that surround Sharps injuries that can affect your entire family, from a statistical point of view, there are 660 scalpel incidences per 100,000 scalpel blades sold in the US. That actually is around 12 to 15,000 within the OR. The 662 covers the entire universe of scalpel blades, which would include everything from hobbyists cutting balsa to make paper airplanes or balsa airplanes to in use in the hospital. Whereas this 3.2 syringes on loose needles, if you look at per 100,000 syringes, you have to understand that there are literally millions of these things sold into the marketplace every day. So while the number looks small, it's actually fairly high. So healthcare workers in the US have reported between 1 and 3 million sharps injuries per year. As I said, 70% go unreported, which I still find insane. 41% of the injuries occur after use and prior to disposal of the device. If you load a blade onto a handle and you cut yourself, it's annoying, it's messy, it's going to require possibly some minor repair in the form of Band-Aids, whatever. But it's still your own pathogens. If you are cut and or stuck post-use on an infected patient, it's a totally different story. 7 to 11% of sharp injuries are caused by scalpel blades. That is fairly high. Scalpel blades are in the top 5 common types of sharp injuries and second only to needle sticks. They're certainly in the OR the most common type of sharp injury, second only to suture needles. If you look at where these who these sharps injuries actually affect, EpiNet, which is part of the University of Virginia, had published a number of years ago a study showing that the bulk of these injuries were incurred by nursing and or surgical techs. As you go downstream, it gets really scary, and that you get down to other, you can see people that are, for example, downstairs in the CNS who are opening up sheets, whatever, that have to be cleaned and sterilized, and find a handle and a blade. I know it's never supposed to happen, but it does. 26% of sharp injuries were due to opening an ampule or a broken ampule. A number of years ago, I attended an AORN meeting that fortunately had 10 to 12 nurses standing around as I demonstrated what not to do. I had taken a handful of swabs, broke the top of an ampule off, immediately cut a large hole in my thumb, and started to bleed all over the table. 10 nurses trying to get my left hand at the same time. It was almost comical, but everybody was concerned. The problem is you don't have to do that. There are enough products on the market that will allow you to open an ampule without having an injury and keeping you safe. Some ampules are certainly more likely to break than others. It really depends on who the manufacturer is. 54% occur to anesthesia personnel, and that's usually because most of the ampules still used in the United States today are fentanyl. To some degree, ampules are used in endoscopy, but predominantly it's the anesthetic people that were involved or are involved. What are your chances of picking up an infection from a needle stick or a sharp instrument injury? Relatively small for HIV, almost nil for a scalpel blade, and that you don't get enough of a viral load in what's left on a blade by the time it gets back to whoever's removing the blade. However possible, hepatitis B should not be a problem, as all of you have been vaccinated against it. Hepatitis C is fairly high, 3 to 10%. Since there's no vaccine as yet for hepatitis C, the expense to your general well-being is increasing incredibly high. We talk a lot about passive safety versus automatic safety, and passive safety has to be better than active safety. And by active safety, if you look at the lower picture of these syringes with caps that get pushed up over the needle, think what happens when you're standing there with a syringe in your right hand and you're trying to cap with your left. If somebody calls your name or interrupts you or bumps you, it's just too easy to get a needle stick. Same holds true for scalpel blades. Therefore, the rule is you must use a single-handed system. And I'll talk about that a little later on in this talk. But CDC studies have shown that 90% of the cases of cuts and or injuries were because the device was not activated. And if you think of your passing bowl, how many times have you looked down and seen that the surgeon has not retracted the blade completely into the handle, leaving the tip out? If you reach in to grab it and are not paying as close attention as you like, or you are being rushed, then it's very easy to get cut. And if I like to make a comment on being rushed, every time I've talked to somebody that has said that they have had an injury, it was always because they were being rushed. The question, they didn't think it would ever happen to them again, which implies that they didn't think they would ever be rushed again, which we know is nonsense. An awful lot of incidences that do occur, I believe, occur because the room has to be turned quickly to allow the surgeon to come in with his next patient and or a new surgeon with a new patient. So people do rush excessively to get in and out. If you look at where cuts actually occur, this was a study done by Fuentes a number of years ago, but still valid, where he looked at where in the hospital, out of 137 incidents that had been reported, cuts and or injuries had occurred. On the scalpel blades, only 3 were on loading, passing 24. Obviously in use would be the highest. But as you go downstream, removing a blade becomes a fairly large deal, disposal, cleaning, and then downstream when it turns up in the CNS. So let's talk a little bit about regulations and what's happening from government control. You're all aware of the CDC's disease control and prevention recommendations titled Universal Precautions. This goes back to 1987. It's everything from wearing double gloves, various practice controls to prevent sharps injuries. 91, it was added to suggesting or demanding that you use safer devices. And this is a kicker, you have to involve employees in identifying and choosing devices to be used. And you must maintain a log of injuries. And by involving employees in identifying and choosing devices, if you aren't participating in the decision-making process on what will be used in your operating room, then you are shirking your responsibility to yourself and to your colleagues. The hospital, the facility must keep a log of injuries, how you've fixed the system so the injury could not reoccur, and a variety of other issues that we'll talk about a little bit later. Engineering sharps prevention devices, or ESIPs, are required. And by required, 59% of injuries with ESIP devices occurred before activation of the safety feature. That is a huge number. Current thinking is safety devices with passive features are more practical than ESIP devices. And what I mean by that, if you look at passive features, we're back to spring-loaded syringes and or some form of retractable that does not require you to physically do anything with a second hand. If you look at the must requirements that changed, you have to select safer devices. You have to be involved in identifying and choosing a device. You need to maintain a log. Engineering and work practice controls will be used to eliminate or minimize employee exposure. Here is the out for surgeons. When the bloodborne pathogen guidelines were really pushed in a fairly large way in the early 2000s, the idea was that you would use a safety scalpel. The problem with safety scalpels is they are inherently dangerous. A lot of surgeons hate them, and they hate them for a valid reason. One, they're slippery when wet. Two, it's difficult to see the geography that you're trying to work in. Because often a safety scalpel is bulkier than a standard handle. And if it's a cartridge that's put on the end of the handle, it's worse. You can't see around it. If you can't see, you are not going to get a good cut. The other issue that a lot of surgeons hate about safety scalpels is often the blade will wobble at the tip. And no surgeon worth his salt wants to see a snake-like scar at the end of any procedure when the patient comes back and everything is removed. So they have the ability to say, I will not use a safety scalpel because I believe that the safety scalpel is inherently dangerous and affects how the patient's outcome. When they go with that process or they go with that thought, you must document it. Meaning if you have surgeons that refuse to use safety scalpels, whether you like it or not, document that they are the ones that refuse to use it. And this is the reason. And use what I've just discussed. Where engineering controls are commercially available and feasible, they must be used. Meaning if you haven't logged at least once a year that you have looked at different devices to be able to keep staff safe, your colleagues safe, then you can be dinged. And that can be very expensive, and I'll go through that in a few minutes. But the use of a single-handed blade remover meets these criteria. And that holds true for needles as well. Single-handed, it cannot be two hands. Using fingers obviously is never a good idea. And I recall years ago talking to a couple of surgical techs who said they were taught how to do it that way and they didn't have a problem with it. Interestingly enough, when I asked the question, how do you get blades off? And they said with their fingers, they first looked around to see if any of their colleagues were looking. So they knew very well that this was not a good idea. Some facilities have used hemostats, needle drivers, Kelly grips, whatever device was available to be able to pop a blade off. If you've done it yourself, you know that all blades come with pilot's licenses. They will fly off the handle, hit the floor, and now you're looking for tape to pick it up, or they'll break. Now you're looking for a way to get the broken piece off. Again, if you're using two hands, the possibility of being cut goes way up, and you are contravening OSHA requirements on how to deal with blade removals and or syringe needle removals. They must be done with a one-handed single-use mechanical device. That is now a must. It used to be a recommendation. Interestingly enough, the AST and their published guidelines require surgical techs to use a single-handed blade removal system. So using fingers to remove a scalpel blade doesn't meet the requirements, obviously. Suggestion that the bloodborne pathogen standard be changed to require that a mechanical device is utilized must be a one-handed use of a mechanical device is a good one and is now mandatory. That number below is the ruling that you can look up. Bending, recapping, or needle removing must be accomplished through the use of a mechanical device or a one-handed technique. Very simple. So good news, bad news. OSHA is now inspecting hospitals. OSHA is inspecting surgery centers. It's requiring incidents reporting on major events, and it's determined to make the environment safer. It used to be that only JACO would come in, and that's what everybody would worry about. And you had a warning. They would typically say, we'll be there next week, we'll be there for 3 days, we'll go through the place. And everybody would run around with their measuring tape to see how high the lowest shelf was off the floor and any other of the standard OSHA requirements that are well known, or CMS requirements that are well known in the hospital. OSHA has found that the most dangerous place to work in the United States is the hospital. Because of the number of complaints that they've received, they are now checking on their own. They're no longer waiting for JACO to tell them that everything is okay. They're going in to check for themselves. And it's interesting, if somebody makes a report to OSHA that they've had sustained an injury in the operating room, two things happen. One, more often than not, it's an anonymous report. So OSHA will write a letter to the hospital saying, we have a report on file of an occurrence of a sharps injury. We would like to know what you have done to avoid such an injury in the future. If you write back with a logical explanation, they will accept it. It will go in a file, and that will be the end of it. However, if they get another letter, they will then trigger an inspection, and that becomes a major deal with a lot of expense. Inpatient healthcare settings have the highest rates of injury and illness among industries. And, you know, when you talk about among industry, that includes mining. If you think about that, you live in an extremely dangerous environment, and your workplace has to spend a considerable amount of time thinking about how to make it safer, and you must participate in that for your own protection. And if you look at the logs that they want, you have to report any injury or fatality within 8 hours, and any work-related inpatient hospitalizations, amputations, or losses of an eye within 24 hours. There's an argument that if you pick up HIV or hepatitis C or any one of the major bloodborne pathogen issues, that must be reported as well, but that'll vary from OSHA office to OSHA office. Worker complaints or allegations of hazards or violations do receive a high priority, as I've described, but you may request anonymity, meaning you do not have to put your name on the bottom of a complaint. Merely contact the OSHA office and tell them you have a problem. Referrals of hazards from other federal, state, or local agencies or the media receive consideration for an inspection. The targeted inspections are aimed at specific high hazard industries or individual workplaces, hospitals, surgery centers, any place where you have the possibility of sharp injuries. If you look at some of the citations that have occurred, years ago, Tennessee OSHA was probably the most active of all the OSHA offices, and their average fine was $1,500 per incident. That has changed. This hospital in New Jersey, I was cited for 9 serious and 6 other less than serious safety violations. Their logs were inadequate. There was an unusual amount of needle sticks and bloodborne pathogen exposures. The fine was $55,000. Very few surgery centers operate with that kind of a profit margin. That could cause one to actually close the place. If you look at another one, New York Presbyterian Columbia University Medical Center, which is a huge facility in Manhattan. If you come across the George Washington Bridge from New Jersey, it seems to dominate the skyline for 10 blocks south of the bridge. They were fined $200,000. And the fines were, again, for the bloodborne pathogen standard. How employers protect their employees against exposure. Major fine, major expense, totally unnecessary if everyone would participate in the whole safety concept within the OR. Case 3 was 15 notices of violations at a VA hospital in Little Rock. Bloodborne pathogen standard and other hazards resulted in what would have been a fine if OSHA could fine it, a federal agency. Obviously it can't, but it gives you an idea of just how serious these fines are becoming. They're no longer trivial, and they shouldn't be. If you go back to 2009, Joint Commission had written a paper that traditional scalpel handles they felt were going to remain the first choice of surgeons, and to ensure staff safety, a single-handed blade remover and hands-free passing techniques would become the norm. It's interesting that safety scalpels have been around for quite some time, but they've never gotten over 30% of the total number of scalpels used in any given facility. 70% still remain the standard handle, and now at least over 60% will have a neutral zone or hands-free passing technique. Not everywhere, and I have given a number of these talks in facilities where that does not exist, and it's a little scary. But if you follow the guidelines from the AORN chapters and certainly the AST, you should be safe. Perioperative team members should practice ampule safety to minimize percutaneous injuries during or after opening of an ampule. Ampules periodically will shatter in your hands when you pop them open, particularly if you pop it in the wrong direction against a scored surface area of the top of the ampule. You'd rather have it break in a device of some kind than have it break in your hand and cut yourself up. So if you're involved in the use of ampules in endoscopy and or in anesthesia predominantly, then it's something to consider and to be careful of. There are devices out there that will allow you to remain safe and avoid any kind of a cut. So OSHA summarizes by no fingers, no forceps, no resheathing. If you use devices that allow you to remove a blade without injury, then you will be meeting the standard. Is legislation enough? If you look at the changes in the Sharps injury rates over the last number of years, overall, there's been a fall of 31% in the non-surgical setting, and in the surgical setting, meaning in the OR theater, there's been an increase of 6.5%. I think that increase is directly related to the amount of pressure to change the theater over to the next patient coming in, but it's still very scary. If Sharps injuries are down overall, and these numbers seem to be consistent with today, 2018-19, a 6% rise in injuries is scary under any set of circumstances. If Sharp safety is dropped off the radar in your facility, get it back on. It's not worth the grief to go through a year of blood tests, worry, and the pain involved in it. Look at the poor results. If you don't care about your safety, why should the hospital? An awful lot of facilities will spend an inordinate amount of time looking at patient safety. What is going on with the patient? What do we need to do to keep the patient safe, well, and out of the hospital? Very few facilities spend any time worrying about staff. Only you can affect that. If you look at unnecessary um, self-sacrifice, probably one of the primary causes for any kind of an injury, nurses, techs, you always want to keep your patient as safe as possible. And you will do things to help them that you normally would never consider doing anywhere else. Think in terms of if a patient falls out of bed and you're going to lift them up. If you weigh 110 pounds and you're going to lift somebody that weighs 260, you are going to hurt yourself. And that is the number one injury in a hospital, period, followed by workplace violence and then sharps injuries. So planning on being safe is critical. A lot of people think they're bulletproof. It'll never happen to me. The number of techs that I've spoken to who have looked at me in the eye and said, well, I was taught how to do it properly. I can take it off with my hands or with a needle driver, meaning a blade now, or a syringe needle, and I will never get stuck. You're never bulletproof. You're never totally invisible. You have to be aware of the potential problems that will ensue should you have an injury. Self-blame, my fault. Yeah, usually it is your fault to some degree or another, but it's the system's fault as well. And if you do not try to change the system to make it safer for you, that it's very hard to get a lot of empathy for some of the problems that can incur in a sharps injury. If you look at a hospital, typically a hospital administrator, and this is not to denigrate hospital administrators, but when they'll look at a patient, and if you look through these glasses, you will see a patient lying in bed, but notice that he does not see the nurse standing next to that patient. So out of sight, out of mind. Selective myopia is as good a term as any. You have to become part of the safety equation. It is impossible to have a safe environment if only one side of the equation, meaning the patient as opposed to staff, is safe. That is something well worth listening to and thinking about. Money. What does it cost? There are hidden costs. There are ignored costs. Someone says that for example, one-handed removal device might cost anywhere from 95 cents to $3, as an example. That's an additional cost to the OR. However, if you look at the typical facility having a couple of injuries a year, that can result in up to $5,000 worth of just blood work, that buys an awful lot of disposable products without having to go through the injury issues. And it does not talk about, or hospitals do not want to talk about, lawsuits resulting from sharps injuries. Because remember, if OSHA requires you to use a single-handed system to remove sharps, then if you do not, your facility runs a serious risk from a legal point of view for not supplying you with the devices that you need to remain safe. So potential solutions, obviously education. And we try to offer education on a regular basis in the form of CEs sanctioned by Fiedler. Action, only you can keep a place safe. And then some of the benefits we can supply you with that will describe what types of systems you can put in place within a hospital to avoid an issue. So you have a choice. If you look at devices that can remove blades single-handedly on the left and or safety scalpels, what have you, on the right, there are different effects and benefits for using the ones on the left as opposed to the ones on the right. Passive against active, we've discussed. I had the retractable safety syringe activated automatically by a spring, blunt needles. All of those things add to the safe environment that you hope to work in. whereas in an active manual system where you have to use two hands does not. So we've talked about why surgeons dislike it. Safety scalpels: light, cumbersome, slippery, geography. 98% of surgeons surveyed in 30 hospitals from the US and Australia dislike safety scalpels and prefer the traditional handles. And it's fairly obvious why. EpiNet published 2003 and multiple journal entries since that 91 injuries caused by reusable scalpels and 42 injuries caused by disposable scalpels or safety scalpels. This was incorrectly interpreted as evidence to support the use of safety scalpels. You're actually 4 times more likely to be cut by a safety scalpel than a standard one. The relative incidence 4 times higher for safety scalpels than for reusable scalpel handles, and you should keep that in mind. If your hospital has 4 safety scalpels on the facility, you're unlikely to be able to change it, but you must be aware that they are more dangerous than a standard handle. Single-handed scalpel blade removers, being passive devices, guarantee higher safety and effectiveness. There's a lot of paper out on this that you can read and that we can supply should you require it. You put a seatbelt on at the end of the day when you want to go home, you're tired. If you put the seatbelt on, it only takes a few seconds. You put it on for 2 reasons. When they first came out, you put it on because the government said you had to and would ticket you. Now it's become just part of daily life. You don't plan on getting in your car, driving home and having an accident. You don't plan on using a scalpel and then cutting yourself with it by accident. You must think in terms of how can I potentially avoid accidents in the future. How much is your life worth? How much does your hospital think your life is worth? I'm going to end this here. There are other video webinars that are available that will discuss different possibilities of use, and I would encourage you to look at them at your leisure. Thank you for paying attention. Certainly appreciate your taking the time. Remember, if you get nothing else out of this, report your injuries and use a single-handed device for both scalpel handles and for needle sticks. Thank you.